So today, slight departure from the sort of talks that certainly I've given to dentists in the past. I've given lots of these talks to GPs, and amongst the many other things that I do, I'm part of the Skin Cancer MDT, and we have discussions about how we can pick cancers up early, because that's always our challenge with cancer. With mouth cancer and skin cancer, if we can pick it up early, there's so much more that we can do for the patient. And so it gets us thinking about, well, so how do we do that? We know that dentists see patients often regularly, every 6 months or so, if we're lucky. What do the figures say? That about 40 million people will see a dentist, certainly at least annually. And you have the expertise, you have the, hopefully, an evolving knowledge to be able to not diagnose skin cancers, but have a suspicion and perhaps refer them on to the GP for onward referral, or directly to the other MaxFac departments. So that's what we're going to talk about today, the evolving role of not just the dentist, but the dental team in managing patients with skin cancer. That's a little bit of my background. So I've been doing it for quite a long time. I did dentistry in Liverpool, medicine in Manchester, in the northwest of England. I've worked in Scotland, I've worked in the Manchester area, and then I've been a registrar here. We moved down here in 2000, and I was appointed a consultant in 2005. I've been the lead for my specialty for the past sort of 9 years or so, and amongst the other things, I examined for the Irish College and for our own college as well, for the FRCS examination. So it keeps us very, very busy. That's what we do. I mean, you know that. So I diagnose and I treat diseases affecting the mouth, jaws, face and neck, which is where today's talk comes in. Most skin cancers present on the face. Going back to what I was saying, you're in the best position to be able to have a suspicion that the patient might have a skin cancer. You examine the face, you examine the neck, you touch the face. When you do all this fantastic implant dentistry and oral surgery that you do, you look at the lip line, you look at the proportions of the face. And I would say to you that it's your professional, perhaps ethical, you have a moral duty to be able to be suspicious of skin cancer and refer it on. You know, if you have a patient with a melanoma and that patient doesn't see their GP, and you saw the patient a year before they present to us in the hospital, a year is a long time in the context of a melanoma. And melanomas can be a millimetre and a half thick, and it's metastasized, and we're talking about, you know, a poor outcome. So I think you've got a bright light. I think you have loops. You have everything that we have in the hospital to be able to pick up skin cancer early. So as part of my work in skin cancer, I'm part of the Skin Cancer MDT. We meet on a Tuesday afternoon and Wednesday afternoon, and we still say if that patient had come in a bit earlier, then there's so much more that we could have done. You know that some cancers are treated with radiotherapy, some cancers are treated with chemotherapy, other cancers are better treated with surgery. The best treatment for skin cancer is surgery. And it's quite a privilege when a patient comes to you. It's not like the general surgeons. A patient has a laparotomy, they have a scar on the tummy. They can cover it with a clothes. You can't cover scars on the face. So some of these pictures that I'll be showing you, just think when I show you the pictures that there is a patient behind the picture. There is a story behind the picture, and try and put yourself in the patient's face and just imagine what they consent to when they have the treatment that we provide for them. So this is what we're going to do today. Discuss the importance of early diagnosis of skin cancer, establish the role of the dental team. As I said, you have a professional, ethical and moral responsibility, and some of the treatment that we do will affect you in the practice. The chemotherapy that we give as adjuvant treatment, the radiotherapy, the surgery, patients have limited mouth opening as a result of the surgery that we do. It makes your job a bit more challenging. So there are the objectives. We're going to give you the common sort of facts, basic facts about skin cancer. A lot of you will already know a lot of this, so my apologies to you. I'm going to assume you know nothing and then sort of build up from there. We're going to have a look at how you can recognize skin cancer, talk about the risk factors. You need to be able to do these things so you can counsel patients as well. You know, I find that certainly when you're doing treatment under a local anesthetic, when you have a patient I don't know about you, but I'm constantly talking to the patient. It's a great opportunity, not just for opportunistic screening, but primary prevention, talking about the risk factors. The lay public still doesn't know about the problems associated with sun tanning salons and sunbeds and things like that. So it's a great opportunity for you to be able to counsel them. And your patients will love you for it. I promise you, it's a practice builder. If they think that you're offering them health professional advice, more than just the dentistry that you do, they will love you for it. They'll stay with you. They'll speak to their friends who'll come and be your patients as well. So I think it is a practice builder. Patients like nothing more. People like nothing more than going home and putting on the TV and watching Holby City or ER. They love the medical side of things. And for you to be able to sort of give them that information, the added sort of value that they're coming to see you, I think is a practice builder. So shall we make this interactive? So nobody falling asleep at the back. So please ask lots and lots of questions. It will help to keep me awake, and it'll help to keep you awake as well. So let's start with them. So the common skin cancers, the three that you need to know about are basal cell cancers, squamous cell cancers, and melanomas. There are other ones, but these are the commonest. These are the big three that you need to know about. And over 100,000 new cases of skin cancer in the UK. Broadly speaking, we divide our cancers into melanoma. That's the dangerous one. That's the one that will kill a patient if you miss it. You can have a melanoma greater than 1.5 millimeters in thickness, and it can have metastasized to the liver or the lungs or the brain. So we need to be able to pick up melanomas early, and I'll show you how you can teach patients to do their own surveillance. The commonest cancer, however, is the BCC, the basal cell carcinoma. So patients don't die from basal cell carcinomas. They don't metastasize, or at least they have to be very, very large before they metastasize. But it's a nuisance cancer because the overwhelming majority of these cancers are caused by the sun. The face is affected by the sun more than other parts of the body. People cover up, but they don't cover most people don't cover the face. And so the problem with the rodent ulcer is that we need to be able to pick it up early because it's on the face. The smaller the lesion is, the smaller the scar, the less disfiguring it is for the patient. At the end of the surgery, we have to be able to remove the tumor. Obviously, that's taken, but we have to be able to restore form and function as well. And the smaller it is, the less challenging for us. The smaller the scars, the less devastating for the patient. So really common BCCs, basal cell cancers. Squamous cell cancers are the intermediate type, if you like. So they're slightly faster growing than BCCs. BCCs will have been there for a few years before the patient picks it up or before you pick it up. Squamous cell carcinomas can grow quite rapidly, and they do metastasize. So we see enough patients in Poole Hospital who end up having prostatectomies, neck dissections, because of the metastasis to the lymph glands. And then the melanomas, the danger ones. Squamous cell cancers and melanomas have a pre-cancer stage. If we can pick the cancers up at the pre-cancer stage, again, there's so much more that we can do. It's horrible, we talk in terms of 5-year survival when it comes to any of the cancers. But if we pick and we treat the cancers at the pre-cancer stage, the 5-year survival is not affected. It's as if they didn't have the cancer. That's the aim, to try and pick these cancers up at the pre-cancer stage. So just a very, very quick, this is the only sort of physiological sort of slide that I'll put on, the epidermis. All three of these cancers are derived from the epidermis, so the superficial layer of the skin. So the basal cells are derived from the cells that sit just above the basement membrane. The melanomas are derived from the melanocytes, which again sit just above the basement membrane. And the squamous cell arise from the granular cell layer. So they're all superficial, which is why they present to us as blemishes on the face. They come out before they go deeper. So broadly speaking, skin cancers are caused by sun. They're caused by UV light, too much UV light, either direct sunlight or sunbeds. This is increasingly a problem. You know, with all the publicity, you think that especially the young people would know about the problems associated with sunbeds, but there's still quite an ignorance about sunbeds in the population. People think that vitamin D is important for us, and light from the sun is important in helping us to generate vitamin D. But actually, you need about 8 minutes of sunlight on your back on a sunny day, summer sunny day, and that's your vitamin D requirements for the day. So people who say, well, actually, I'm sun tanning because I want vitamin D, that's wrong. There are better ways of getting vitamin D.
Take supplements.
Or take supplements. The two main ways are natural. So I don't know, how many of you take supplements? Yeah, because I would expect probably all of you to take supplements. So to some extent, we're protected. I'm protected because of the color of my skin. People who have dark skin have more melanocytes, have more melanin, and it's that absorbs the UV radiation from the sun that protects us. People who have light skin, blue eyes, light-colored hair, blonde, red hair, have very few melanocytes, and they're at risk of burning and not tanning. And in the summer months, probably we don't need vitamin D, but certainly in the winter months, most of us need vitamin D. It's not a vitamin that can be stored in the body. You know, you get your requirements day by day. So I take vitamin D supplements. So I'll give you these top 10 tips now. When I examine for our colleges, I have to give a talk on diversity, equality and diversity, and we talk about biases. There's a bias where people in the audience, or when I'm examining, you listen to the first part of the talk, and then you listen to the last part of the talk, and you end up sort of sleeping through the middle part of it. So my take-home messages I'll give you now, and I'll give you them right at the end as well. So when you're talking to patients, and especially if you've got the vulnerable patients, you've got those who have fair skin, lighter, freckly complexion, blue eyes, who you think might be vulnerable, patients who are immune compromised, either because they're on immunosuppressants because of autoimmune diseases, or because we all, I'm sure in our practices, have patients who've had transplants, solid organ transplants, kidneys and liver. They're on immune suppressants which make them very, very vulnerable to skin cancer. Now, most of them will be in the hospital setting. They'll have attendances in dermatology and maxillofacial departments, but still use it as an opportunity to educate patients. So protect skin with clothing. That's a hat, a t-shirt, and UV protected sunglasses. Your hat has to be a broad. There's nothing better than mechanical protection. So physically keeping the sun off your face. So that's a broad-brimmed hat. 3 inches, we say, keeps the sun off all of your face. Glasses, make sure your glasses fit properly. They don't sort of wander down your nose. That will protect you. Stay in the shade. The maximum amount of UV light during the day is between 11 a.m. and 3 p.m. when the sun is at its highest in the sky. And so we're not saying don't go out in the sun, but just be sensible. Casual sort of going outdoors in the sun, going from one place to another, absolutely fine. But don't sort of sit and lie in the sun between 11 a.m. and 3 p.m. in the British, in England, in the summer months. Use sunscreen. We'll talk about sunscreen and the importance of it. Greater than SPF 30 or SPF 50 for children and those who have pale skin. And also use a sunscreen that has UVA protection as well. It's not just UVB that does the damage. Most of the aging, again, I'm sure patients come to you and you put in fillers and you put in Botox, but the best way for anybody to stay young is to stay out of the sun. And it's the UVA that causes aging, photoaging. It causes coarse collagen and leathery skin and the pigmentation that's associated with the aging process.
May I add something?
Yes.
We have to renew as well the sunscreen.
Absolutely, yeah, because people are not good at following instructions, and it's said that you should renew your sunscreen every 2 hours. When you're out on the beach, using towels to dry yourself, going into the water, if you have an abrasion or something like that, the sunscreen comes off. Now, there are manufacturers who produce this 8-hour plus sunscreen that they claim lasts for 8 hours or so. And that might be true, but actually, so if you just missed behind the ear and you've got the 8-hour protection on, well, that part is going to get sun for the rest of the day. So it's good practice to renew it. And those claims about 8-hour protection are only effective if the patients use the ounce on all of the affected, the exposed parts of the other body. People are very bad at using sun protection. So the advice is to use enough, in fact, overuse it and use it liberally, rather than get one of these 8-hour-a-day ones that you apply once and then forget about it. You'll forget about it when you go in the water and then come out. It will have gone. So yeah, good point. And obviously, young children and babies are more vulnerable, so we keep them out of the direct sunlight.
What about the water resistant ones?
Yeah, so again, so the ones that are water resistant and those that last for 8 hours or more, they're still subject to the to the person being able to apply them correctly. So yes, those claims from the manufacturers are correct, but it depends upon people being able to apply it to all parts of their body and not missing anywhere. And but even the water-resistant ones, when you dry yourself with it with a towel, they come off. People can become very sort of lackadaisical when it comes to sun protection. They think that they've applied it once and that's it.
Sorry, we were told by our GP for our 8-year-old when we were going to the beach that you should really not be applying the sunscreen for the first half an hour because of vitamin D, etc. Because we're being bombarded with sunscreen and media everywhere else and put sunscreen, and they're not getting enough. It's sort of blocking their absorption of vitamin D or their sort of production of vitamin D. So don't put it for the first half an hour and put it later. Is that correct?
I think it depends upon how long you're going to stay out in the sun. They've done so much work on sunscreen, and the problem with sunscreen, as you quite rightly say, is that it stops the absorption of sunlight, which is important for vitamin D production. But it's quite complicated. It depends upon where you live. The people who live closer to the equator are much more vulnerable. They need to stay out in the sun for a shorter period of time to get the protection. So somebody like me with my sort of Fitzpatrick, maybe 3-4 type of complexion, I need to stay in the sun for much longer than you, if to get the same amount of vitamin D. So it's very complicated. Depends upon the individual, how much natural melanin they have, where they live, whether it's what time of day it is, what season it is. The general advice is that you put sunscreen on about 20 minutes before you go out, and then you replenish it. For young kids to get the maximum vitamin D, the sun to manufacture vitamin D, they need to be in the sun. If they're fair-skinned, they need to be in the sun for maybe about 5 minutes, something like that. That gives them their daily dose. Now that's the summer months. Summer months between 11 and 3 in the morning. As the sun goes down, the UVB, which is important for vitamin D production, is absorbed by the atmosphere. It's coming in obliquely. Only part of your body is subjected to it. So the 8 minutes and the 15 minutes, 5 to 8 minutes for children and the 15 minutes for adults, depends upon the sun being above you. So it's a bit more complicated than the manufacturers would claim.
With children, would it be so when they start school? I mean, they're as young as 4, but there's now a rule where the teachers are not allowed to apply sun cream on the kids, so the 4-year-old has to do it themselves, and usually they don't do a very good job of it.
No.
So would it be okay to just apply it in the morning before they leave, and do you think that would be sufficient enough as they play outside?
Do you know what? Kids especially do all sorts of things, don't they, with their body, and they wipe it off, and they,
That's the problem, yeah. So it's
in Australia they have dispensers in the schools themselves, so the kids are taught to sort of apply it themselves. Now 4-year-olds are not going to be, some 4-year-olds are perhaps not going to be compliant with that. I think, so with children, you do the best you can, which is, as you said, to apply it, but make sure that, they're not going to go out in the vest or in the shorts for the bulk of the day if they're going to be outside. So I think mechanical protection is probably as important as, if not more important, than sun factor protection. So, but you're right. I think teachers don't like sort of touching kids, and they don't like applying the.
They're not allowed to. That's
Mm.
the thing. So, but you know, my son usually comes back with patches of sunscreen all over, which obviously has.
But that's good. So it's having an
really
effect.
irritating.
Maybe
I-
we should have another session here for kids.
I think you can educate kids, though. I think you can, start that education process early, and if they see mum and dad doing it, so probably your son, doesn't need the same sun factor protection that that a very fair-skinned child has. That's right. Sunbeds. This is a real sort of bugbear. Sunbeds increase the risk of cancer, including melanoma. There's no doubt about that. We can't even argue about it or discuss it. And there's no good advice around it to the public. The customers themselves choose the frequency and the duration. There's no clear advice. This is the problem with sun tanning salons. Everybody advertises the health promoting benefits of sunbeds, and you'll see them in David Lloyd Centre and in health places in sports gyms and things like that, as if it's part of the sort of the promotion of a healthy lifestyle.
So there's no regulatory body who.
Well, there is some. So there has been some legislation that's come about, but it doesn't go far enough, really. So we know that sunbeds before the age of 35 doubles the risk of melanoma. This is the legislation. So under 18s are banned from using tanning machines, in the way that you can't buy cigarettes if you're underage. You can't use a tanning machine if you're under 18. But it's not very well regulated. So there are no licenses or anything like that are revoked if companies are flouting these regulations. It's very poorly monitored. We know the first exposure to sunbed before the age of 35, as I said, increases melanoma by 75%. So this is, the evidence is so stark that who have reclassified sunbeds as group 1 carcinogens. So they go in with all the polycyclic hydrocarbons that are in cigarette smoke, alcohol, and so forth. There's really no debate around sunbeds. As I said, the legislation doesn't go far enough. So they're used by tanning, cosmetic tanning suites. Public information, there should be a bigger public information campaign about the risks. There should certainly be a ban on any health claims by the manufacturers. Advertising should be scrutinized. They should be staffed. Often the staff aren't there to ask or to answer questions, or if they are there, they're not knowledgeable. It's a money spinner, sunbeds. And certainly those under the age of 18, those who have fair, freckly skin, large number of moles, history of skin cancer, sun allergies, shouldn't be using sunbeds. So if your patients present in those categories, you should be telling them, look, for your own health, you shouldn't be using the sunbed. So this is the other message. After this, if you fall asleep, I don't mind. But those two, this one on sunbeds and this on mole checks, really important. We know that melanomas either start off as a new blemish after the age of 40. You're allowed to have moles on your body. Some people are born with moles, they're congenital moles. Some people acquire them later on in life. But moles after the age of 40, you should regard with suspicion, and patients should keep an eye on them. Because if those moles are asymmetric, a nice circumscribed, one color within it mole is perfectly okay. But asymmetry in a mole is not allowed. That mole then needs a biopsy. If the borders are irregular or ragged, or where the mole sort of fades into normal skin, that's not good. The color, if there are multiple colors within it, we don't mind a black mole, a brown mole, a blue mole, as long as there's uniform color within it. If there are multiple colors within it, that's not good. And evolving, so this was something that they added with time, evolving change.
What about the size?
I beg your pardon, diameter, yes. So moles, small moles, again, okay. Large moles, this is probably the least important because you can get melanoma within small moles, but as a general sort of rule, moles bigger than 6 millimeter are the ones that become melanoma. It's quite rare to have a small mole that's changed into a melanoma. And then evolving change. So if a mole changes with time, if it itches, if it ulcerates, if it bleeds, then that's a risk factor that it's transforming into a melanoma, and it needs an urgent biopsy. So that's the ABCD guide of checking moles. I said that most skin cancers are caused by the sun. Well, the sun UV radiation is UVA, B, and C. UVC is absorbed in the atmosphere, so we hardly ever talk about UVC. UVA is the one that's associated with sunbeds and that can cause cancer, but that can also cause aging. UVB doesn't cause so much aging in the skin as UVA. UVA damages the elastin in the skin, and it makes the skin, the person, vulnerable to wrinkles. It causes pigmentation within the skin. It gives a leathery complexion to the skin. So UVA is not good generally. And the important thing is UV, because people talk about, well, if I'm indoors and I'm in the, in the room at the back in the sun lounge, am I still protected? UVA penetrates windows and glass, so it will still have its effect. This is the one that causes the majority of skin cancers, and it's the one that's responsible for sunburn. It's strongly linked with melanoma and BCCs. So sunscreens, broadly speaking, there are two types of sunscreens. There are the fillers and the organic fillers and the inorganic fillers. The organic fillers are the ones that absorb the sunlight. And they're also called chemical screens. They act as sponges, and you need to keep replenishing them. And organic doesn't mean they're environmentally friendly or anything like that. It's just the fact that they have chemicals within them rather than particles. These are the inorganic fillers that act as, they reflect the light. And these are mainly zinc oxide and titanium dioxide. Both need to be replenished. And there's no good evidence that one is better than the other. There have been talks about sunscreens themselves perhaps causing cancer. There have been talks about the inorganic fillers, whether the titanium dioxide is absorbed, whether that causes cancer. But there's no good evidence to support that. So sun protection factor is very, very important. So that's a marker of the ability of the screen to absorb UVB. It's nothing to do with UVA, it's UVB. And we generally say that greater than, this is the range that they come in, between 30 to 50 will confer protection that you need. But as a general rule, protective clothing, staying out of the sun between those the hours 11 a.m. and 3 p.m. and using the sun protection factor. UVA is assessed by a different scale. So when you look at the back of the packaging for a sunscreen, you'll see the sun factor protection, whatever it is, 30 to 50, but you'll also see a star rating. And the higher the number of stars, the better the protection. And so UVA, you're looking at between 4 to 5 stars to give you the right protection. And actually, these broad spectrums, if you buy a broad spectrum sunscreen, because they'll write that on the packaging, that gives you UVA and UVB protection. And it's important to look at the photostability. So when you read the packaging, you need to know that these don't break down in the sun. Some fillers will actually break down in the sun. They're not very photostable. Down here, the incidence of skin cancer down here is just phenomenally high, it really is, because we see it reflected off the sand and we see it reflected off the water. We get the direct sunlight in the summer months, and we get the double whammy if you're close to the water, reflection off the sand and reflection of the water. And of course, when you go skiing, it's reflected off the snow. Snow increases UVB by up to 85%. So I mentioned the Fitzpatrick classification. Again, I'm sure how many of you do put in fillers and put in Botox and things like that? Do any of you do?
I used to.
Okay. Yeah. So you'll know about the Fitzpatrick skin biotypes. You can very quickly classify your patients into these categories. 1 and 2 are the patients who are most vulnerable. 5 and 6 are the patients who are least likely to get skin cancers because of the large number of melanocytes in their skin and the melanin production. So these are the fair skin, the blue eyes, the red hair, the blonde hair, the freckly complexion. So we worry about these patients. And actually, so this is quite a good representation. So 1, 2, 3, 4, 5, 6 people fall into those categories. Vitamin D. So this is where there is a debate between sun protection and not having sun protection, because you need vitamin D. Vitamin D is important for our bones. If you don't have vitamin D in childhood, you get rickets. If you don't have it in adulthood, you get osteomalacia, osteoarthritis, with all the problems that come with that, fractured hips and so forth. It protects against cancers. It's thought that high levels of vitamin D protect against bowel cancer. It's important preventing arthritis, autoimmune diseases, multiple sclerosis, diabetes, dementia. The list goes on. Vitamin D is really important in the body, and this is what the recommended sort of daily dosage is. And I said that exposure of the skin to UV is affected by, it's a complicated thing, lots of things: time of day, the season, the latitude, altitude, whether there's cloud cover there or not, the clothing and sunscreen. So everybody needs vitamin D. It protects against all those diseases. You can test how much vitamin D you have in the body by a simple blood test. So if you have the blood test looking at 25-hydroxyvitamin D, within that range you're thought to be deficient. This is sufficient, and this is excessive. We mentioned that you can get it in the either a supplement or in the diet. The diet isn't a very good source of vitamin D, so you can't make good the vitamin D that you haven't got because you haven't been in the sun by diet. Oily fish, sardines and trout and salmon give you a little bit of vitamin D. In our diet, most of it is fortified in cereals and in milk. And we've got an at-risk group who are vitamin D deficient, so pregnant women, breastfeeding women, young children, the elderly, those who cover their body are more likely to be deficient in vitamin D. So you can get it from the diet, but diet isn't a very good source. Supplements are a better source for vitamin D. And you need to be sensible about it. If we have a really nice summer, you don't need vitamin D. When we have a winter, and you're not one of these who sort of goes to the Caribbean maybe 4 or 5 times a year, then you do need to supplement it. We've said that. So turning to the other cancer. So these are the ones that you need to know about. BCCs, rodent ulcers, they're by far the commonest skin cancer. They're a nuisance cancer. They need to be treated because if they're left untreated, they can grow really quite large. When they're close to the eye, the surgery can be disfiguring. When they're close to the mouth, when they're on the nose, the surgery can be disfiguring. We need to pick them up early. Typically age greater than 60, they don't metastasize. There's a genetic predisposition, Gorlin-Gold syndrome. You'll all sort of remember from BDS, I'm sure. I've got about 5 families who have Gorlin's syndrome, and we see them because they develop keratocystic odontogenic tumors. They develop the jaw cysts. But we also see them because they develop skin cancers on the non-sun exposed parts of the body. So they start developing skin cancers when they're quite young and in their teens. And their face and their body is scarred because they've had multiple attempts to remove these skin cancers. They do grow themselves out of that predisposition to develop skin cancers later on in life, but so that's a genetic susceptibility. This is the sort of the area, the high risk area, if you like, on the face. 70% of 70-year-olds will have 1 or more basal cell carcinoma. That's how common these are. These are the different sort of presentations. We won't go into detail about those, but this is how they present. So they'll present as a nodule On the face, you do something called a stretch test. So if you suspect somebody has a blemish, you stretch the skin. If you stretch the skin, if it's benign and innocuous, it will tend to disappear. If it blanches and is flat, it's more likely to be a vascular lesion rather than a skin cancer. But if you stretch it and it persists and it's nodular, then there's a good chance that's a basal cell carcinoma. So this is and again, there's no doubt what this is. We don't need to biopsy it. This is a barn door basal cell carcinoma. And a lot of them will present like this, maybe not on such an obvious sort of, on the forehead, but anywhere on the face. And so these are nodules that appear pearly white and that have telangiectasis on top. That's a basal cell carcinoma.
Excuse me, with regards to the example of the skin, when you stretch it and it's not, and when you stretch it and it is, can you repeat?
Yeah, so when you stretch, yes, so if you stretch the skin, okay, and the lesion persists and it stays the same, you can actually see wider margins if you stretch the skin. The margins of the lesion become much smaller. If you stretch the skin, the lesion presents itself to you. It's more likely to present itself to you as being a BCC. Yeah. So stretch is really important. And you get similar lesions. The nose is a really common site. The nose projects into the sun. The upper lip is protected because of the shadow of the sun. The lower lip projects into the sun. Ears are a vulnerable site. People like me, thank goodness I'm protected because I've got melanin, because otherwise I'm bald and I'd have to have I have a cap in my hat, in the car, but I have to wear it all the time. The scalp receives a lot of the sun. So circumscribed, pearly appearance, overlying telangiectasis, and when the little nodule outgrows its blood supply, it starts to necrose in the center. So that's a BCC. And there's no treatment for that other than surgery. Now, you can have a lesion 4 times as big as that on the cheek, and the surgery is straightforward. Under a local anesthetic, you give it a margin, and the patient heals with a nice little line scar. On the nose, that's quite difficult to treat without deforming the nose. There is an earlier version of a variant of BCC called a superficial BCC. These can be treated with topicals and they don't necessarily require surgery. So when you look at these are quite well defined. You can feel these before you can perhaps see them, because if you feel them, the edges are sort of almost thread-like, slightly raised but thread-like. And they're thin plaques. They might have central ulceration. They may have some pigmentation. These are superficial BCCs that are not dangerous and that can be treated with topical agents, which we'll look at in a minute. So risk factors for BCC: sunlight, artificial light, tanning booths, ionizing radiation. I've got a young girl from South Africa who had treatment for lymphoblastic leukemia on her scalp when she was 7-8 years old. And back in those days, the treatment was radiotherapy on the scalp. And she's now in her 30s, and she's developing skin cancers all over her scalp, really. She's got a full head of hair. She's very pretty, but very attractive, but she's got multiple skin cancers on her scalp. And we removed them. I removed, under one general anesthetic, about 6 skin cancers from her scalp. She's under a surveillance program because she's going to get them on her scalp. This is the bit that had the radiotherapy, and she's developed 6 others. So radiotherapy, ionizing radiation, is a risk factor, not just for BCCs, but for SCCs and melanoma as well. Arsenic, water contaminated with arsenic. Transplant recipients form an important part of our group. There's a condition called xeroderma pigmentosum where patients can't repair the damage that's done to the DNA. We all get damage to our DNA with sunlight, and most patients, that damage can be repaired, but they lack the gene that allows it to be repaired. Personal family history: 30% at 3 years. So if you've got 3 or more first-degree relatives who have a skin cancer, your chance of getting a skin cancer is 30% at 3 years. And skin types 1 and 2. So the treatment, as I said, you have everything that you need to be able to diagnose this: an inquisitive mind, a bright light, and loops. and the treatment for it is surgery. There is for lesions that are close to the eye, where you want to minimize the margins, that are close to the nose, where you want to minimize the amount that you can reduce. There's a technique that the dermatologists use called Mohs micrographic surgery for removing skin cancer. When we conventionally remove any cancer, we give it a wide margin, and we don't know it's all out until we actually get a report that tells us it's all out. But that report, the way they section the specimen, it's a bit like bread slicing the specimen, only looks at 1% of the margin. For BCCs, Mohs micrographic surgery allows them to look at 100% of the margin. The downside to it is that the patient sits in the chair, and under local anesthetic, they have a skin cancer removed, and the dermatologist goes next door, has a look under the microscope, does some frozen sections. That tells them where it's still present. They go back, take a little bit more, look at it under the microscope, and come back. I've had patients who've started their treatment under local anesthetic at 9 in the morning, and at 7 o'clock in the evening, they're still going, and I get referrals from them. So Mohs is really labor intensive, it's cost intensive, and we don't think it's the best way forward. The problem is, I showed you that slide at the beginning, and the training that we've had to be able to operate on the face. Dermatologists do a medical degree, and they specialize in dermatology, and those that want to do surgical dermatology will do a 6-month course, Cardiff University or somewhere like that, that gives them the ability to be able to operate. Now that's okay if you're operating on the back or on the arm or on the leg, but not on the face. And we have those robust discussions amongst ourselves in the MDTs. So I know if anybody has a skin cancer, I know I would refer it to, on the face, I would refer it to either plastics or maxillofacial surgeons. Radiotherapy, there's only a minor role if patients are not fit for surgery. And cryotherapy, well, so cryotherapy and laser therapy. Pulse dye laser, for the BCCs, I showed you that they have telangiectasis on top. If you can obliterate that telangiectasis with pulse dye laser, then the lesion will often resolve. Or you can ablate it with CO2 and erbium YAG laser. And then there are topicals, but these are really second and third line treatment. The principal treatment is surgery. Prognostic indicators, as with most cancers, the tumor size, the histological subtype, if the BCCs are into blood vessels, if they've got increased number of mitoses. Patients who've had recurrent BCCs are at risk of getting further ones, more BCCs, and immune suppression. So squamous cell carcinoma is the second most common cancer. 20% of all the skin cancers that we see, they're derived from the granular cell layer, which is quite close to the surface. So these will cause surface changes that you'll be able to see. Again, people over the age of 60, they often have a potentially malignant or a pre-malignant condition, an actinic keratosis. If we can pick it up, I'll show you pictures of that in a second. If we can pick it up at that stage, then that's better for the patient. And they have a potential to metastasize. About 500 deaths per year in the UK because of metastases from a skin cancer that might have a 90% 5-year survival. If it metastasizes to the neck, that 5-year survival is halved. We're talking about 40%, 40 to 50%. So it's important we pick them up before you pick it up as a lymph node. And the prognosis for squamous cell carcinomas on the skin is better than it is for the oral cavity. So if you suspect somebody has an SCC, it's good practice anyway. You examine the lymph nodes in the neck. The differential diagnosis of SCC is actinic keratosis. There's a condition called keratoacanthoma that mimics a squamous cell carcinoma. It's an aggressive nodule. But if you leave it for 8 weeks, it involutes and it resolves. It falls off. The problem is it mimics an aggressive skin cancer. And current practice is that you don't wait for it to involute, you have to take it off. And when we do take it off, sometimes a report comes back saying that was a keratoacanthoma. And then Merkel, I said that melanoma is the deadliest skin cancer. There's actually one that's even more lethal than the melanoma, and that's a Merkel cell carcinoma. 30% mortality when it presents to us. They can be really quite small. They behave in bizarre ways. They occur most commonly on the face in the elderly, but you can have a Merkel cell here, and it can have metastasized to the nodes on the other side. It doesn't seem to follow any rules of cancer progression. And that's a Merkel cell carcinoma, because that's from a slightly deeper layer where the melanocytes are. then it presents more as a nodule, a red nodule. The surface generally isn't broken.
Do all these have symptoms?
Do they have symptoms? So Merkel cell can be painful, but all the other cancers, pain isn't a feature of them. What patients will tell you is that they had a blemish and they thought it's only small and that it's getting bigger, but then it's all gone, it's settled down. But then it comes back 6 months later as the same blemish, it crusts, it maybe bleeds, and then the crust falls off and they think it's all gone, it's resolved. And then when it comes back 3 months later, it's usually a bit bigger, but that's how they progress. Pain isn't usually a feature. It's a blemish that's not settling, but that's itching or crusting or bleeding. Even if the crust falls off and it comes back, then that's a suspicious sign.
When you feel for it, what is it quite hard? Or is it...
Normal skin, normal mold and normal skin should feel nice and soft. I mean, even somebody who has, marks from acne or something like that, it's still nice and soft. And we tend not to worry so much about teenagers. My son's got spots, and I know that they're spots, and they sort of come up and they go down. But certainly anybody in their 30s and their 40s that develops a new blemish that you can feel, okay, and that might have a history that it's going, but then it comes back in the same place, that's a skin cancer unless it's proven otherwise. There is no other benign condition. Benign conditions, if they're there, tend to persist and they don't change. So those that change, come and go, tend to be skin cancers.
Is melasma precancerous or?
No, not at all. No, there's no pre-malignant potential associated with melasma. So risk factors again for SCCs, UV radiation. We've seen this before, except for squamous cell carcinomas, smoking and cigars on the lower lip are an independent risk factor. There are some syndromes, familial syndromes, xeroderma pigmentosum we spoke about. Chronic wounds, if you have any chronic wound, be it in the mouth or on the skin, if it's there for a long time, on the skin, we call it a marginal tumor. You can get SCCs that develop in burns, typically in burns patients, because that breach, the skin is so important as part of your defense against infections, and if it's breached, for a long period of time, it lets in all sorts of environmental carcinogens and infections. So the breach in the skin for a long time is a risk factor for skin cancer. Viruses, HPV, that should say, HPV 611, you know about HPV because of its association for mouth and throat cancer. Well, this acts as a co-carcinogen. It needs other things for it to act as a carcinogen. Ionizing radiation, the immune suppressants, history of non-melanotic skin cancers, skin types, and these we've looked at. So, and again, we've looked at these. So the treatment, the mainstay in treating skin cancers is surgery. We know that with a basal cell carcinoma, if we give it a 4 millimeter margin, 95% are clear. With a squamous cell carcinoma, a 5 millimeter margin will give us a 95% cure rate. Radiotherapy for patients who are not fit for surgery, where surgery gives a 95% cure rate, radiotherapy gives an 80% cure rate.
When you say 5 millimeter margin, you mean
yes.
5 millimeter clear of the lesion?
So when we look at it under the bright light and with our loop magnification, we mark out what we think, what we feel, and what we think is the cancer, and then we've got to give it 5 millimeters.
Off, yeah.
Yes, yeah.
Thanks.
There are some topical agents that we can use for skin cancers, but again, they're for the very for the pre-cancer stages. So this is what an SCC looks like. I mean, again, this is a cancer. This is not. If the patient has traumatized the lip, they'll give you a history of trauma. But this is something that's fairly slow growing and it's not healing. It's nothing else. It's a squamous cell carcinoma. We don't even need to biopsy that. We treat that as a squamous cell carcinoma with the right history. The lip is quite a common site for skin cancers. And the main treatment is surgery. You can see if we pick them up early, then they're less disfiguring. So for the high-risk patients, a photoprotection we've spoken about. Chemo prevention. So we know that patients who've had organ transplants where they're going to get multiple skin cancers during their lifetime, there's quite a lot of research looking at the role of vitamin B3 and retinoids as long-term sort of treatment to prevent them developing further skin cancers. Nicotinamide is important because the sun damages ATP. ATP is important for metabolism in cells. The sun damages ATP, and nicotinamide replenishes the ATP, and it enhances DNA repair. And it's been shown to reduce the number of skin cancers. So ordinary vitamin B3 helps people who are prone to getting skin cancers. Retinoids, well, these are vitamin A derivatives. The one that we use mostly is called acitretin, just given as a tablet, can, like nicotinamide, reduce the number of skin cancers they get. And then this is the one that will kill you. This is the melanoma. And the melanoma can be, as I said, 4 or 5 millimeters just in. It's not so much the length of it that's important, it's the depth of it. When we look at melanomas, we measure prognosis by something called the Breslow thickness. So that's how deeply it's invaded in the tissues. And we say that if you have a melanoma that we've biopsied and the Breslow thickness is 1 millimeter or less, they have an excellent 5-year survival, 90% 5-year survival. If the Breslow thickness is greater than 1 millimeter, then you're looking at a significantly reduced 5-year survival. So melanomas we have to pick up early. Most melanomas arise actually, they have an in situ phase, so they have a precancerous stage. As I said, Breslow thickness predicts their survival. This is the incidence. The incidence is increasing, 40 per 100,000 in Australia, 10 per 100,000 in the UK, and rising. It's rising, it's increasing faster than any other human cancer. Melanomas are more common in men compared to women, but under the age of 40, they're more common in women compared to men. We see them in men on their scalps, on their neck, and on their back. In women, it tends to be on the limbs, on the legs, and on the arms. Not exclusively, but sort of as a general sort of rule. And about half of them have a mutation. This is a really important mutation that we test for when we have a melanoma. If they have this mutation, then they respond to monoclonal antibodies. So it's the most lethal skin cancer, 6th most common cancer now in the West. It affects not just the skin, but anywhere where you might have melanocytes. So the eyes, the oral mucosa, meninges. We've had a patient just very recently with a nasal melanoma. He had his, I haven't brought his investigations, or maybe I should have done. When I get time, I'll put them on here. He had a scan 3 weeks ago that showed the melanoma. He had a biopsy by the ENT surgeons. It proved it was a melanoma. 2 weeks after that, it's invaded the skull base and is now inoperable. That's how quickly melanomas spread. Especially the mucosal melanomas. They seem to have an aggressive behavior compared to skin melanomas. So any new pigmented lesion or changing pigmented lesion on sun-exposed skin in somebody who's over the age of 40, you should regard that as with suspicion. And survival is correlated with the tumor thickness. So risk factors, UV radiation, as we've already said. You can have one sunburn in your youth and you develop a melanoma later on in life. That's why it's really important to keep youngsters protected against the sun. More than 5 sunburns doubles the risk of melanoma. Daily use of sun protection factor reduces it quite significantly. These are the patients who are most vulnerable: fair skin, light eyes, light hair, freckling, those who have very freckly complexion, personal or family history, and immune suppression, patients who have solid transplants. So it presents on sun-exposed skin as a nevus is just another word for mole, as a changing mole or a new changing mole. There's this sign called ugly duckling sign. When we see some patients, they have so many moles on their body that you think, goodness me, where do I start looking at these? But one will stand out. Most of the moles look roughly the same. One will stand out, and that's a sign that mole needs to be biopsied. Lentigo maligna melanoma. So this is a superficial spreading melanoma. So look, so there's one color there, There's another color there, and there's a third color there. So that's not a normal sort of mole. It's got an irregular edge. If you were to divide that, whichever way you half it, it's not symmetrical. So that's a melanoma unless it's proven otherwise. This is a lentigo malignant melanoma. So with BCCs, we give them a 3 millimeter margin. With SCCs, we give them a 5 to 6 millimeter margin. With melanoma, it depends upon the Breslow thickness. Because if the Breslow thickness is 1 millimeter or less, we give them a centimeter margin. If it's greater than a millimeter, we have to give it a 2 centimeter margin all the way around that. Yes, it's essentially, I've got a picture I'll show you in a minute. So again, you can see that, you know, that they have got multiple sort of colors within them. I mean, this is a melanoma. Whichever way you look at it, that's a melanoma. It's not a spot. It's not a, you know, it's nothing else. On the skin, there's no tooth underneath that's got an abscess on it. That's a melanoma. So these are the ones that we get in Asians and dark-skinned patients. This is amelanotic. So you think, my God, that looks aggressive, but actually this is the melanoma. This is entirely benign. So although you might think that actually this has got multiple colors within it, why is that not a melanoma? Okay, so this is a lesion called a seborrheic keratosis. Seborrheic keratosis. And it's classic, it's an age spot. Some of us will get them, others won't get them. They're as common as moles and freckles are. And essentially, when you look at it, it's got scales on it. So you can see little tiny scales. And it almost looks as if it's a waxy thing that somebody's stuck on the face. You can get around it, you can get underneath it. And some of these will come off and they'll go. Other patients will get more and more of these. So this, for us, is not a diagnostic dilemma. It's a benign condition called a seborrheic keratosis. And if you look at your patients, you'll see it in the hairline. You'll see it, women get it on the backs where the bra straps are, and it catches. Sometimes we take them off. Men get it on the hair when they're shaving, on the face when they're shaving, and it catches, and we take them off, and we just curette them. So this is nothing nasty, but that's the one that we worry about there. So prognosis. Stage 1 melanoma, less than a millimeter, hasn't metastasized, 85 to 95% survival. Stage 2 melanoma, bigger than a millimeter, hasn't metastasized, 40 to 70% 5-year survival. Stage 3, any melanoma with a regional lymph node, 25 to 70% survival. Stage 4, if it's metastasized to distant organs like the liver or the lung or the brain, 10 to 15% 5-year survival. And it's only 10 to 15% because of the newer monoclonal antibodies, the targeted treatment that keeps patients alive for a bit longer. So investigations, excision biopsy. We do staging scans for anything greater than 1A, sentinel lymph node biopsy. We used to do neck dissections on patients. Now we harvest the sentinel lymph node. So we inject radioactive dye near the melanoma. That's the day before the surgery. The day of the surgery, we inject dye, blue dye, near the melanoma. And then we use a Geiger counter in theatre to tell us where that dye has gone from the melanoma. And wherever it's gone, we harvest those 1 or 2 lymph nodes and check those. Because if they've got melanoma in them, then we do a neck dissection. If they haven't got melanoma, then we don't do a neck dissection. It's reduced the number of neck dissections we do quite significantly. And this was just to say, those stage 3 and stage 4 melanomas that have a really poor outlook, there is now chemotherapy, there's immune checkpoint inhibitors. These are quite commonly used now in our skin MDTs for patients who've got metastatic melanoma, as are these, targeted molecular therapy. So relevance to the dental team, coming back to this now, I said at the beginning that you know, given that the majority of skin cancers present on the face, and as a health professional, you look at the patient's face and you spend time with them. You know, if you're doing a bridge or a crown prep or something like that, or you're doing root canal treatment, you're looking at their face. I think you've got a duty to have an awareness of skin cancer, not to treat it, and not to diagnose it, but to have a suspicion, high index of suspicion, and refer it to the GP or refer it to the MaxVac department. They don't need to go through any triage centers or anything like that. They come directly to the MaxVac department. I have a patient with either a new blemish on the face or is worrying. The patient said that it's been there for a little while, it's changing. Please, could you have a look at it? Just a simple letter. So most cancers occur on the face. Early diagnosis saves lives. Not just saves life, but it's less disfiguring for the patient, as you'll see in a minute. I think we're all sort of bright enough to know what the risk factors are, and we can cancel those patients. Oh, I beg your pardon. Sorry. Did I do that before and you went out? You certainly should have health information leaflets and posters in your practice. Your patients will like you. It will make your practice stand out. It will make you seem, as you are, caring professionals. You're interested in the welfare of the patient. And I think it's a practice builder for you. The surgery that we do will cause problems for you because it can cause microsomia, will cause problems for the patient, oral hygiene. It'll cause problems for your hygienist. It'll cause problems when patients put dentures in the mouth. It can result in loss of vitality for the teeth, for the lip, if it's a skin cancer on the lip. The radiotherapy causes xerostomia with all its problems, mucositis, ulceration, trismus, osteoradionecrosis. So these are the direct effects of the treatment that we give for our patients with skin cancer. Chemotherapy causes problems. So chemotherapy is very much a third line. Mucositis, ulceration, hematological side effects. Patients get a low platelet count and they're vulnerable to infections. So that was what I wanted you to take home. You can either fall asleep now or you can go. This is the surgery that we do. So this is sort of less important. It's how we reconstruct and repair. We use something called the reconstructive ladder. So we start with very simple things: primary closure, skin grafts, local flaps, pedicle flaps. If the lesion becomes very big, we use free tissue transfer, and sometimes we use alloplasts. And so all of these, the main treatment, the prime treatment modality is surgery. And these are the high-risk areas on the face. These are the danger zones. There was a Russian pathologist called A.L. Yarbus who looked at patients' faces, and he thought, I wonder what people see when they meet somebody new for the first time. And so he, in the 1950s, it's quite a novel thing to do. In the 1950s, he put transducers on the extraocular muscles of the group that he was testing, and he gave them pictures of famous celebrities or famous people, and he scanned their eye movements to see what patients do with their eyes when they're presented with a new face. And this is what patients do, or what people do, not patients do, what people do. When they meet somebody new, they look at the eyes, they look at the nose, they look at the mouth, everything is here, and then they start to look around the rest of the face. And that's given rise to a philosophy of reconstruction that we use now. And that is that if you can get this right, for most of the skin cancers I'm going to show you, we have to bring tissue from somewhere else on the face or from distant parts of the body. But if we're going to bring it from the face, it's important that we keep those scars minimal, okay? But we have to get this right. We have to get the eyes right, the nose right, and the mouth right. And so that's given way to this concept of facial aesthetic units. So this means that if somebody has a skin cancer on the forehead, where we can, we use tissue on the forehead. We stretch tissue across this way. The forehead has a different complexion, has different skin characteristics, color, thickness, the number of glands, the vascularity compared to the cheek. And the cheek is different to the nose, and it's different to the upper lip, it's different to the chin, it's different to the tissue around the eyes. So where possible, we like to keep reconstruction within an aesthetic subunit. We don't like to cross it. The nose is one of the most difficult parts of the body to reconstruct, and so specifically within the nose, there are 9 aesthetic subunits. So if somebody has a skin cancer on the lobule, where possible, we like to keep the reconstruction to the lobule. We don't want to take it from the cheek and stretch it across the lobule. It doesn't make for a good reconstruction. So very simply, somebody has a skin cancer on the face, on the nose, then if it's stretchy, we'll stretch it across, and that will heal very nicely with primary repair. If somebody has a large skin cancer like that, there's no way we're going to stretch that skin across. And in the elderly, the simplest thing to do is to remove that and put a skin graft on that. Skin grafts can either be full thickness or they can be split thickness. So when we clean this up, got rid of the crust on it, this is what we're left with, and we give that a margin. So yes, so skin grafts can either be full thickness or they can be split thickness. The advantage of a full thickness skin graft is that the color match is better. The skin is thicker, especially on the scalp. If you put a split skin graft on, if the patient bangs their head, it breaks down, and there's a cosmetic deformity there as well. So where possible, we like to put full thickness skin grafts. And we can take that from the neck, because the closer we take the skin graft to where we're going to put it, the better the color match. But the full thickness skin graft depends upon a vascular bed. It has to, the place where it goes on has to have a good blood supply. And if it's got a good blood supply, the blood will revitalize that skin graft. If we put it directly on the skull, it can't be a full thickness skin graft. It won't take, because the blood supply to the skull is very poor. And so then we put a split skin graft. So this is what we use to harvest our skin grafts. This is what we use. This is a bit like when you harvest a skin graft from a palatal graft, you have little tiny dermatomes inside the mouth. So this is a dermatome. And when that breaks down, we resort to the old-fashioned Humvee knife for taking skin grafts. And we get something like this. And that's the donor site. That will heal like a graze will heal. And we apply it to the scalp, and that's what it looks like 3 weeks later, and that's what it looks like 6 weeks later. It's a split skin graft, so you see the divot in it. And that's what the donor site looks like. And so this is a skin graft on the nose. That's what it looks like immediately. We found that the simplest way of dermabraiding skin for us is to use sandpaper. So we sterilize sandpaper, and we use that to abrade the skin. And so that lady's nose becomes like that. This is after we've dermabraided it, and that's her perhaps about 2 or 3 months later. Local flaps, so on the scalp is really forgiving. You can do lots on the scalp and it heals quite nicely. But we can remove that basal cell carcinoma, and this is called a Burroughs flap. We borrow skin from Peter to pay Paul, so we stretch it across from where you've got more skin to cover where the skin is quite loose. On the nose, we do these Burroughs flaps. So because this is here, we like to keep the reconstruction there. Skin grafts, if we can help it, are not very good cosmetically. They're a different color. It looks a bit like a patchwork quilt. So where possible, we like to move tissue around. It's the same color, the same quality, the same texture. And so this is a patient who's had this procedure. But to get the best result, we have to undermine it. To really stretch the skin across, we have to undermine it. That's what he looks like immediately after the surgery. And that's what he looks like just before the sutures are due to come out. And that's what he looks like. Because we've kept it all to the aesthetic subunit, it actually looks okay. So we can remove this as a basal cell, and we put this here, and we put that there. And the stretch here just allows the nice sort of line scar. And that's what she looks like. And there's a lot of stretch in the glabella. So cancer's on the nose. We can use the stretch in the glabella to pull it down to cover the nose. In the elderly, this is a really good reconstruction, because as you get older, the tip of the nose tends to fall. It tends to drop. And one of the side effects of this is it pulls the tip up. So that's the byproduct in the elderly. They end up with a more youthful looking nose than they had before. So this is a squamous cell carcinoma on the lip. We have to remove that with a margin. You can see it's a bit bigger than the previous cancers. So that's the margin we give it, and that's the transposition flap that we're going to use to repair it. So it's a full thickness defect because it was indurated. That's a denture that you can see underneath shining through. And so that heals like that. And it still distorts the lip, but it's actually, in the context of what she's had, that's an okay reconstruction. This is a patient with a melanoma. I remember what I was telling you about the margins for a melanoma, the 2 centimeter margins that we give these. So that's the defect. Now that's not going to stretch together. It's close to the eye. We don't want an ectropion. Lesions close to the eye. We have to be careful where we put the scars. We can hide them in the skin creases underneath the eye, the blepharoplasty skin crease, but we don't want to pull it. So all the pull has to be from the side here. We can't have it pulling down like this, otherwise they get an ectropion. This is a cervical rotation flap. We utilized the stretch in the skin to move it across to cover it, but it was not enough. So we've also taken a paramedian forehead flap to reconstruct that. So there's a flap on the forehead and a flap on the cheek, and we rotate it across, and it eventually comes together. That's him immediately after the other surgery. He'll need a second operation to detach the pedicle that this part of the skin is based on. Ear reconstruction is a specialty in its own right. So in this country, in the West, when we remove a tumor from the ear, we try and get the shape right. Because when I look at you, I see one ear, and I have to sort of stand here to see the other ear, or I have to come really close up to you to see both the ears. So the principles that we use are, we work to a conversational distance. And with ears, if we can restore the shape, there's such a variation, one ear bigger than the other in the same person, between people, that if the shape looks okay, then the ear looks okay. In America, they have multiple operations where they get the height of the ear right, but I think in this country, just as a rule, we try and get the shape right. And we do something called a helical rim advancement flap. And that will heal beautifully. That will look like an ear because of the wide variation in the scalp can be quite difficult because the skin is so tight. If we're not going to have a skin graft, the problem with skin grafts on the scalp, especially in women, is that they end up having a bald patch. So we can do big cervical scalp rotation flaps to cover it. And that's what he looks like at the end of the surgery. And that's how it heals. So they heal quite nicely on the scalp. So the nose is a really difficult part to reconstruct. Within a very small area, you've got the lining on the inside, you've got the skin on the outside, and you've got cartilage in between. And if your cancer involves all three, you have to reconstruct all three. If the defect is small, we can pinch a little bit from the ear, so the skin and the cartilage, and we can use that to reconstruct, just as a free graft. And it always looks a bit pale immediately after the surgery, but then it settles down quite nicely. You can't see where it came from the ear. If you have a little notch on the nose, people notice it. And the nose is one of those, remember I showed you that picture where people look at the nose first of all to see if it looks right. So composite grafts for very small defects. The paramedian forehead flap, I'm sure you know about this. This is the workhorse for nasal reconstruction. We do a lot of our reconstructive surgery on the nose, if it's extensive, is based on this flap, which was used in 700 BC. It was used in India by a group of potters who became very good at reconstructing the nose. The punishment back then for misdemeanors, for crimes, for adultery, for robbery, was to amputate the patient's nose. And so people became very good at repairing and reconstructing the nose. And it allowed the offender to rehabilitate back into the society if they were able to reconstruct his nose. Otherwise, it was a great punishment. You knew immediately, if you met somebody in the streets and they'd had their nose chopped off, that they'd been a naughty boy. And so people became very good at reconstructing the nose. And we still use the same techniques for reconstructing the nose as Sushruta Samhita did back in 700 BC. The techniques have been modified over the years by Antonia Branca in Italy and further. But we depend on this. This is an artery, the supratrochlear artery, that supplies the forehead. And we rotate that down to reconstruct the nose. So we have a template of the defect up here, and we're simply going to rotate it down to reconstruct the nose. That's what it looks like, sort of pictorially. And we can thin it right down. It's got such a good blood supply. And this is how it looks when we've detached the other pedicle 2 weeks later. The skin of the forehead is such a good match for the skin of the nose. It's just uncanny. And the vertical scar, people have horizontal and vertical scars on the forehead. It doesn't detract. So this is a patient. He had a full thickness defect on the nose. It's one of those difficult things to reconstruct, not just to be able to get the shape right, but also to make it functional so the skin doesn't collapse every time they breathe. So we took some cartilage from the opposite ear. Is usually a good match for the cartilage for this side of the nose. So we put the cartilage in from the conchal bowl, so from inside here, and that stiffens the nose. And then we have a template that's based on a pedicle, and we turn it down to reline the nose. We can't detach it and use it as a skin graft because it's too thick, So this is where I was taking the cartilage from the ear. That heals beautifully, but that space there is such a good match for the nose. And that's what it looks like immediately after the surgery. So these poor patients have 3 weeks where they've got a little pedicle on the nose, and they don't like to go out. They stay at home for 3 weeks. But that's what it looks like after we've detached it. So this is him 6 months later. Now, I'm a bit critical, that's a bit narrower than this side, but actually that's pretty good for, for reconstructing the nose. And the scar on the forehead, you hardly ever see. That heals beautifully. And that was him. All of these patients have given me permission to show their photographs. This was I said there's a story behind every patient. This was a university lecturer from Bournemouth University who had an SCC excised by the ENT surgeons, and he had a prosthesis. And one day he was giving a lecture as I'm giving it, and the prosthesis came off in front of everybody. And he became really embarrassed. He developed a habit where every time he gave the lecture, he would do this to make sure that it was still there. And he developed this mannerism where he would do this. So he came to see us. And I spoke. We've got a fantastic laboratory in Poole Hospital. I can't praise them highly. Mark and Heidi. So we decided we'd make him a prosthesis because he didn't want scars anywhere else. But we put a little implant in here, a craniofacial implant in, that would retain it with a magnet. So this was him after I'd cleared him up. This was Mark taking the impression of his nasal cavity for the prosthesis. And they do amazing work with these silicons. They've revolutionized what we do. This is the little implant, so just between his central incisors. And that has a little tiny magnet on it. And that retained, that's its keeper. That retained that prosthesis for him. And he was so happy. He was so happy. So when they get bigger, there are some things that we can replace with the body's own tissue, and some that we can't. There isn't enough tissue there. But we do put implants in the piriform area. So this patient had a squamous cell carcinoma on the nose. This is from when I was a registrar in Salisbury and a few years ago. And we put a couple of implants in here, skin grafted that defect so that it looked like that, and then again made him a magnet-retained prosthesis. So this is him with the prosthesis, and this is him 10 years later. And as they get older, we can change the prosthesis. We give them one for the summer and one for the winter because the color of the skin changes in the summer and the winter. It becomes lighter in the winter. And again, he's very... And those that have elderly, that have arthritis, they have poor hand sort of coordination, they just need to bring it close by and it sticks into place because it's magnet retained. They don't need good eyesight to be able to sort of put this in place. And they can take it off, they can put it on. This is another patient. So this patient had a squamous cell carcinoma on the nose, except he had post-operative radiotherapy. The tissue here wasn't very good for implants. Radiotherapy, as you know, significantly impairs the take of implants. There's something like a 60% failure rate if we put implants in the head and neck, in the craniofacial region. We used a clever idea. So these are titanium screws that are just screwed into the piriform fossa. And they're called epiplates. It's a French idea. So we screw them in, and this is what comes out into the nasal cavity. This one was a conventional implant, but we put two magnets on these again, like that. And this is him. Everybody looks the same when they've had the nose off. It's uncanny that the nose is so unique and individual to us that when you take the nose off on patients and you look at them from the side and from the front, people look similar. They don't look the same, but they look similar. The nose is so unique to us that you don't realize it until you do a rhinectomy on a patient. So that was him without his nose, and that's him with his prosthesis. And again, that's thanks to our prosthetic laboratory. They are amazing at what they do. And we do the same sort of things with eyes. And again, the implants are really good in this in the craniofacial region. And by the time that he's got his glasses on there, you'd walk past these people in the street and you wouldn't notice. Okay. Some people actually prefer to have a patch on their eye, and that's fine. Everybody's different. It's they feel happier rather than having to stick something in place. This is with the ear. So again, that's his ear. And again, you'd walk past him in the street and not realize it. And they can be retained not just on magnets, but on bars. And for the more complex defects, that's his tongue that you can see there, because his maxilla is gone. So for the complex defects, You know, again, it's not brilliant, it's not perfect, but it allows him to sort of go outside. It gives him a bit more confidence. Yeah. These are all skin cancers. So last 2 or 3 photographs now. So you think you've seen it all in the West, and then one day I was operating in theatre, and an SHO came to see me to say there's a lady in the emergency department and she's got an infection around her nose. And I said, well, you know what to do the blood test, do her glucose and put a drip up, give her antibiotics, and we'll see her. And by the way, which tooth is it coming from? And he said, no, I don't think it's coming from a tooth. So I went to see her. So this is a BCC. Basal cell carcinomas don't kill you. They're locally aggressive. This is why it's called a rodent ulcer, because it gnaws away at the tissue. Very bright lady, but a hospital phobe. She worked in a library, didn't like hospitals, and until this got bigger and bigger. So she came in, and I remember being in the clinic with Professor Lankavan when she came in. And he said, well, look, the first thing that we need to do is to get these 2 teeth out because they're hanging on by a thread. And she said, whatever you do, don't take the teeth out. It's funny, isn't it, how different things are important to people. She said, no, do whatever you want to do, but don't take these 2 teeth out. We said, no, it's fine. We'll be able to send you back to your dentist. They'll be able to put implants in there, but those teeth have to come out. So she didn't want to have the treatment, and she went to have treatment with this drug called Vismodegib, which is a hedgehog pathway inhibitor, which is along the sequence to lesions becoming skin cancers. And went away for 1.5 years, and actually it didn't do her anything. In the process, she ended up losing her hair having treatment with the chemotherapy. Came back to us and said, I'd actually quite like to have something done. So this was the resection. Because this is a BCC, there's no need to do neck dissections or anything like that. This is not going to metastasize. She's got an implant here. She's actually got 2 more implants there, and she's got implants at the back here as well that will retain a denture for her. And as I said, she'd lost her hair, and she wore this wig. And that was her with a prosthetic reconstruction. And she's ever so happy, she really is. When I see her now, we joke about her wig, and I say, people are not going to notice this, you have to get a better wig. That's what they're going to point at.
Sure, the upper lip doesn't look really nice when she
no, because there's stretch here. But the problem is the BCC has scarred this tissue so much that she doesn't have the same movement in the muscles here.
Oh, yeah.
But it allows competence. The upper lip is slightly easier to reconstruct with silicons and with a prosthesis compared to the lower lip.
Yeah,
the lower lip goes and it's impossible to reconstruct that. Then you have to reconstruct that with surgery. And then you think you've seen it all. And then I was operating, this is my patient now, I was operating about 2 years ago in theatre, and another SHO, our SHOs are only with us for 1 year, they sort of come and go like ships in the night. Another SHO came and said, Mr. Ramchandani, you've got to come and see this patient. She's got an infection around her eye. And I said, well, you know what to do. And then I thought, no, maybe it's not an infection, because I've already tried that once before. So he said, come and see this patient. I had a registrar who was operating with me, so he carried on operating. I went to the emergency department, because that's where she presented. And she was sitting with all the other people in the waiting room in the emergency department, and she had her hair down her face, down 1/2 of her face. As was, you know, people used to do that in the 70s and the 80s. It was fashionable. Gabriella, the sort of pop star, used to have her face covered with hair. And who's the other patient, the other singer, I forget her name. She always has her hair down her face. I can't remember. I wish I could remember her name. Then I could say I'm youth. That's it.
Yeah.
Yes, yes. So she has her face covered. So this lady was sitting like that. And I thought, okay, well, let's get it into a cubicle. And then when this is Ina, by the way. This is her beginning to the end. And you can see her eyes. She's now glowing. She's so happy with that. There's no makeup or anything like that on her face. This is how she is. This is how she was before she went to have a treatment with Vismodegib. As I say, she lost her hair with the chemotherapy, but she got that. So this was the lady. So this is in the West. So let me tell you. So nothing surprises me in Poole Hospital. So her story is that she used to work for what do they call them? A tour operator. You know, if you want to book a holiday, we most of it do it online, but you can actually go to a tour operator and they can book it for you. And she, 8 years before this, she developed a little blemish near her eye, and she thought, oh, it's nothing. And it grew slowly, And she thought, still nothing. She didn't like coming into hospital. She was living in London at the time. And then it continued to grow. And then she thought, oh my God, this is a cancer and I'm going to die. What's the point of even going anywhere? I'm going to die from this. So she let it grow and she let it grow until she lost the eye, the vision in that eye. And then it was only when it started to encroach on the other eye that she thought, hang on, this can't be a cancer because I should have died from this cancer. It's got so big. But patients don't know. BCCs, you don't die from BCCs unless they invade up towards the brain, and even then you can have craniofacial surgery to remove it, but they don't metastasize. It's when it started to encroach on this eye that she came in to seek help.
But isn't it painful?
No,
No.
these are not painful because they're slow growing. A dental abscess that comes on suddenly causes a sudden increase in pressure is painful. These are not painful. She wasn't taking any tablets. So she was obviously washing it.
Did it invade the frontal side?
No, so we did the scans and it was just, yes, I'll show you the defect in a minute that she caused. So she only came to us because it started to invade it started to encroach on her other eye. And you will not believe this, but she told me and her sister told me that 2 weeks before she came to us, she had gone into work. And she had been going into work and she'd had her face covered. They obviously knew there was something wrong, but she was such a hospital phobe that she didn't want to come into hospital because of the devastating surgery that she might have.
Did any professional knew about her, kind of like a GP or a dentist?
She didn't engage with GPs, she didn't engage with hospitals at all. She wasn't diabetic, she wasn't hypertensive, she had no other reason to see a GP. She just kept this covered.
Dentist, no?
Because she didn't engage with health professionals, she was almost not quite a recluse because she was going into work, but very frightened of the healthcare profession. So that was the prosthesis that Mark made for her, and that was her. That I've got it actually on another presentation. I forgot to put it here. But her defect included the orbit, the maxilla, the nose, as you can see here, and the eye. And it.
One slide back. No, the prosthesis. After this, that's it. Thank you.
Wow.
And again, and she comes in so happy. She really does. And that's thanks to our prosthesis. That's Mark and Heidi. That's our laboratory in Poole. They do amazing work there. They really do. We couldn't be able to do that without them. Okay.
Thank you very much for such a...
I'm sorry that's gone on. Actually, I didn't mean it to be so late.
One comment, please. Due to the fact that I'm working a lot with blood concentrated, we were discussing
yes.
earlier.
Yeah.
There is a professor in South America that works a lot with these kind of patients where there's defects, and they use only PRF clots.
Yes.
Only.
Yes.
Without any local regional flaps or whatever, and you get healing. So
yes.
I'm not talking about these
yes.
huge cases.
Yes. But for patients who've had radiotherapy or patients who've had to improve the quality of the tissues, IPRF, especially IPRF, that acts as a volumizer.
About the clots, even if there's a defect, a big defect like that, they fill it up with the clots
and cover
it heals.
Okay, I mean that's where modern day research is, isn't it? And that's where I think we're heading, using the body's own potential to heal itself.
So other than the visual inspection, is there any blood markers for these types of cancers?
No, not for BCCs, SCCs, or melanomas. When the melanoma metastasizes, LDH increases in the body. There are markers then, but by that time it's stage 4 disease. You won't be seeing patients with stage 4 disease.
Seeing that it's on the increase, is there going to be any sort of things where patients like in Australia, they have to go for a 6-monthly cancer check? Is that going to be introduced at some point?
So do you know what? So we have a high-risk group of patients who come in for regular mole checks because, no matter, we teach our patients, especially the high-risk patients, we educate them, as I'm asking you to do to your patients, and we teach them to examine themselves, so to examine their neck. We see them for 5 years. If at 5 years the cancer hasn't come back, they're essentially cured. We talk about 5-year survival as being the cure. And so in the first year, we see them every month. In the second year, every 2 months. Third year, every 3 months. Fourth year, every 6 months. And fifth year, every 6 months. So we do keep an eye on them. But by the time it gets to, and the risk of it coming back the next year is lower than it was the previous year. Time is really important in this. The risk of it coming back after 4 years is less than it was after the first year. If cancers come back, 80% will come back in the first or the second year, and then a small proportion come back later. Now, somebody who's under 6-monthly review, it's conceivable that they might come back before we see them. So we teach them how to examine the face, how to feel the neck. They become obsessed at looking in the mirror when they're brushing their teeth. The bit that they can't do is examine their back, or the bits that they can't get to. And then we encourage their family, if those that have a family, to examine them. But things like the ABCD check of melanomas, most people can see that, and they can do that themselves. But the high-risk ones we do get back, and we see them regularly. But not I think the resources aren't there to be able to see everybody at regular intervals.
So one question: do hairdressers pick up on these much?
I get more referrals from hairdressers than I do from dentists, which is why I'm here. There's 2 that we've had recently. One was an amelanotic melanoma. Because people become attached to their hairdressers, I've got no hair, but I always go up to Wigan in the northwest, where I grew up as a little boy, to get my hair done. People become attached to their hairdressers, and the hairdressers get used to sort of knowing that. And so we get lots of referrals from hairdressers. You're absolutely right.
Yeah, I was wondering if it's something they get in their training. Is it something there's more of an awareness for them, so they're able to pick it up?
Yeah, I think you're right. I think you're right. And if something new, if something changes, they'll pick it up before the patient will pick it up, before the person will pick it up. It's interesting.
Yeah, because I get sunburn on my head occasionally, especially in the water.
Yes.
That flattens out. You've got a bare patch.
Yes.
But I don't look at the top of my head much.
Yeah. But so you should feel. So that's important. Feeling is as important as looking at it, actually. But get your family to your partner or something like that to have a look at it. Thank you. It's my pleasure. I'm sorry that's gone on.